Hello, everyone. Welcome to another edition of the Stanford Health Policy Forum. My name is Keith Humphreys. I'm a professor of psychiatry here at the university, and I coordinate this series, which is supported by the Office of our Dean, Dr. Lloyd Minor. Policy Forum convenes a couple times a year to bring top health policy thinkers and doers to Stanford to engage with us and engage with the broader community, and we've got a great opportunity to do that today. Our next event will be in the winter. We haven't quite nailed down the speaker, but if you want to know about that, or for that matter, look at forums that we've done before, all of which are filmed, you can do that at our website, which is just Health Policy Forum, all one word, .stanford.edu. This particular event we did in partnership with Stanford Center for Innovation in Global Health, and it's been a wonderful chance to work with them. And to introduce our panel is my co-conspirator, the Deputy Director, Kathy Burke.
Thank you. Stanford Global Health is really delighted to be able to join forces with Health Policy and Anthropology to make this event and two more events over the next day and a half happen here at Stanford. Our center, which is based in the medical school but works across the campus, fosters research, education, and community in the area of global health. And we welcome your interest and inquiries. Our website is Stanford Global Health, or globalhealth at stanford.edu. I'll get that down. So today, it's my pleasure to introduce Dr. Vikram Patel. He is an Indian psychiatrist and researcher, best known for his work on child development and mental disability in low-resource settings. He's the co-founder and director of this Center for Global Mental Health at the London School of Hygiene and Tropical Medicine, where he is a professor, although he is moving in April to Harvard. Dr. Patel's work spans a wide variety of topics. He works in epidemiology, medicine, psychology, disability, neurological disease, non-communicable disease, public health, substance abuse, economic evaluation, and implementation research. But his primary interest is in improving the care and treatment of people with mental disorders worldwide. Angela Garcia is a professor of anthropology here at Stanford. She is interested in the disproportionate burden of drug addiction mental illness, and incarceration among low-income populations. Her work involves social sciences, humanities, and public health, and she looks at the dynamics of inequality, vulnerability, and sociality. Since 2011, she has been working in Mexico City, examining the informal treatment of addiction in centers there. She is part of a binational research project that examines a mutual aid group for low-income Latinos with addiction or mental illness. Paul Costello, finally, is the head of media and communications at the medical school and an excellent interviewer. So I set you all on
Thanks,
go.
Kathy.
Thank you.
Thank you. Dr. Patel and I met earlier today. We did a podcast together, and he told me of a unique cultural experience he had. He came in from Chicago last night, and Chicago Cubs and the fervor. So he saw this unique American experience, and he said everyone at the airport was, cheering, and so it was the World Series euphoria that you got sort of a glimpse at the time you were here. I wanted to start off with giving some definition to the term global mental health movement and how the global mental health movement is different from that global health movement or the prior sort of international health movements. What's the difference here and what are the similarities?
So first, if I can just respond to the cultural bit. I come from a part of the world where the game that was being played is completely unknown. But we have a game that I hope to teach my friends in Boston when I move in April called cricket, which is, for those of you from the old Commonwealth will know what that game is, which is probably even more complicated than the game that the Cubs were playing last night. I
think you'll have a better opportunity to change global mental health than you will to teach cricket in Boston. But,
You're probably right, yes. It's not an easy game to explain. Anyway, so first of all, global mental health. It's a relatively young discipline, and in my mind, it is a child of primarily the discipline of global health. So it's essentially the application of the principles of global health to the specific area of mental health. And the most important principle of global health, which I think distinguishes it from international health, is its focus on health disparities. That is to say that the focus of our actions is on reducing health inequalities, both between populations, such as, for example, between developing and developed nations, but also within populations. And so therefore, global health and global mental health is also a discipline that's relevant to this country, because there are enormous health disparities in the US as well. Just in final, there's a wonderful statement that my mentor, Srinath Reddy in the Public Health Foundation of India, uses to describe the difference between global health and international health. International health is an older paradigm in which it was very much about the global north with all its resources, intellectual, financial, etc., saying, what can we do for you in the less resourced part of the world? Global health, as he described it, is what can we all do together to help each other.
you know, you mentioned something interesting just there in what can we all do together, because that brings in Angela, who's a cultural anthropologist, who looks at places and neighborhoods and people in a very, as you called it, deep dive. So how do you see the bridge to global mental health movement, cultural anthropology, and what you do? How do you link those together?
Well, one of the things I'm interested in is what new kinds of coalitions and forms of activism might global mental health help to generate. So not just only the professionalization or the upscaling of clinics or resources in low-income settings, but also what kinds of cross-disciplinary conversations might it help to bridge and generate. So for me, working with low-income kind of folk healers who engage in modalities of care that are not necessarily easily recognizable as care, and also scholars who have an understanding of religiosity in particular settings, who can sort of see where these modalities come from culturally and in terms of different religious practices. Working with economists, working with people, my area of particular interest is addiction, people who are working in hemispheric conversations around drug policy, and trying to bring them together, and also, of course, bringing to the table those who are most critically affected by illness and by violence and by the disparities in healthcare access. And so I think there is a real opportunity to create these new coalitions within this kind of overarching discipline or science that is called global mental health. I am a little bit concerned, however, that with the increased professionalization of this movement, that we may lose some contact with these broader kinds of engagements that I think are essential to really...
Why do you think that will happen? What leads you to believe that?
Well, I see the institutionalization of global health programs in universities, which I'm on the one hand very excited about and want to participate in and help foster, but I also see how that institutionalization can, which is often, many of the sort of sources behind it, might ultimately create greater distance between what is perhaps happening on the ground and what the goals of particular interventions might be, or scientific projects or programs might be. And so this is an opportunity, I think, for us to sort of exercise some caution and to think critically and expansively about even the categories of health. What does health even mean? Another interesting cultural encounter I had was even coming this morning and having to swing by the supermarket to get something for my children and looking at all of the health magazines. women's health, men's health, healthy living, and the kind of normative picture that was presented in those, and then thinking about, well, almost perhaps imagining what would a global health magazine look like? What kind of actor would be on the cover? What kind of image would they be representing? And so I think we have an opportunity to sort of begin to question these things, and certainly they have been questioned. But my interest is in trying to kind of maintain contact, close contact with the communities that are struggling and striving to care for each other in the context of not having professional care available to them.
You're almost, but not using a word that we talked about earlier today, is disruptive. And here in the Bethlehem of disruption, I wondered, what both of you think about the notion of that the way in which we look at mental health globally, the resources, the lack of resources there are, that what really needs to take place is a disruption in some respects.
Yeah, well, first of all, before I go to the disruption question, I wanted to follow up on something that Angela said, which I think is something quite important, which is the danger of losing the local as we apply the global. And I think actually there's a fundamental tension here. The tension is between the need for all countries to actually make a fair healthcare system available to everyone in the population, something which we all acknowledge is a fundamental human right in the form of, say, universal healthcare. In that particular context, the need for healthcare providers, policymakers, decision makers to have a common language, a standard way of understanding health conditions, and that includes mental disorders and the treatments. And that's on the one side. And on the other side is the need to also acknowledge that health is a very complex, multidimensional phenomenon where cultural and social and environmental factors are profoundly important, and those are often very different from one context to the other. So I don't think there's an easy answer to that question, but I do agree that actually I think the need to find that right balance is extremely important. Now, turning to the question about disruption, I think there are really two important first of all, we do need to have disruptive innovation. If we carry on doing business as usual as we do, say, for example, take this country as perhaps one model of mental health care, or indeed any kind of health care, it's astronomically expensive. It's far more expensive than any other country on the planet, including other rich countries. And yet there are huge gaps, both in terms of coverage as well as the quality of care. And many people tell me that it's not just in developing countries that people with mental health problems are tied up. In fact, in this country, they're put in prison. So I think one has to acknowledge that simply throwing more money at this problem is not going to actually solve it. In fact, it's going to bankrupt people. I think disruption allows us to look at a problem with a completely different way, through a completely different prism. And I'm sitting in the home. This area is the home to perhaps the most exciting opportunity for disruption, which is the digital technology world, which I think potentially offers all parts of the world, but particularly the parts of the world I work in, and particularly with young people, an opportunity to really leapfrog human resource barriers, literacy barriers, a variety of other barriers to improve access to healthcare more broadly, but in particular, mental health care.
Play that out. How do you see that unfolding?
So, for example, consider the access to information. If I had to get any information regarding what's happening in my life, in my heart, in my mind, depending on what particular idiom you use for mental health, the digital world offers you an immediate portal to get information. Of course, there's an issue about how good that and how useful that information is, but it is a portal for information. Let's go to the next stage. From information, if I want to assess how my mental health is, the digital world offers us a variety of new tools, some which are very innovative, for example, using gaming interfaces to assess what my mental health might be like now. Let's go to the next stage. Once I have a sense of what the assessment tells me, what can I do to actually address some of the difficulties I'm having? Again, there's a whole range of new technologies for self-care, with or without guidance from someone remote. So here are just some examples, but I could go on. There's tremendous innovation happening in this field. My only one worry, I'll say one worry that I have is that actually it's gone viral to the point where there's so much out there, but most of it is undocumented, it's unevaluated, and therefore I think what we need to do from the global health community is to actually partner with this incredibly imaginative IT world to see how we can actually evaluate some of these innovations and ensure that, in fact, they're doing at least some good and no harm.
Both of you have really touched on, in some respects, the limitations of the biomedical model. What are its limitations as you move around the globe? What's not transferable and what is transferable?
Well, speaking concretely, in my previous work on opiate addiction, specifically heroin addiction in northern New Mexico, where I worked and where I happen to be from, and which has suffered some of the highest rates of heroin overdose in the U.S. for generations. And it's a region where it's a rural region, very little healthcare, professional healthcare available. I was there studying opiate addiction and overdose in particular as it manifested within multi-generations of families. And at a time in which the sort of medical regime was kind of coming in and introducing this notion of chronic diseases, addiction as being a chronic relapsing brain disorder. And I saw the way in which that explanatory framework interacted with a local framework of having experienced multiple cycles of loss of land through cycles of colonialism, loss of jobs, loss of language, and the sense of endlessness that both the chronic illness model coupled with the model of despair, depression, multi-generational experiences with poverty, entrenched poverty, how that was a toxic interaction. And so in that sense, the biomedical model, a model of addiction as chronic relapsing brain disease, might actually be very beneficial for some people struggling with addiction. It might be empowering, it might give them a sense of hope. On the other hand, in this particular context, again, where it was so essential to kind of really deeply understand the local, I could see the incredible danger of that narrative in the way that it mixed with a kind of local ethos of suffering and created really an inescapable environment. On top of that, too, the criminal justice model, which is addiction is still ultimately a crime and thus is treated, through the carceral, mechanism. And so there it was just a real, there was a tension between these three models, essentially, and for locals struggling with heroin addiction and struggling with it, within families, within multiple generations, within one particular household, it was really had a devastating effect. So in that sense, that's a kind of very local example of some of the ways in which the biomedical model is not one that is necessarily one that can necessarily help propel people out of suffering. Yeah.
What has been the impact of the pharmaceuticalization of mental illness and mental health? How has that impacted the globe? The intense marketing efforts. I don't know how deep that is and rich that is outside of the U.S. I know it is very rampant here. How has that changed as it grows, as pharmaceutical companies have more reach globally? How does that alter the issue of mental health?
So that's a really pertinent question. First of all, let me tell you my understanding of actually what is the access to pharmaceuticals at the moment. Whereas I think it might be true that in this country, the problem may be the overuse of psychotropic drugs. Certainly if I look at the recent data on how many children, for example, are put on psychotropic drugs, it seems quite an enormous proportion compared to any other country. The problem in most parts of the world that I work in is that there are actually no psychotropic drugs. So it isn't a problem of overuse, but it's a problem of no use. It's a completely opposite problem. To give you an example, about 80% of people with chronic schizophrenia in India receive no medicines for schizophrenia. Now, admittedly, medicines are not the only solution by any means, but they are part of the solution. And the fact that such a large proportion of people with one of the most serious mental health problems receive no medicines often means that they're tied up at home. So it's not as if they're wandering around happily and doing something else. No, they're actually physically restrained because partly the behaviors they have causes concern and difficulty to the family. So my agenda really is not reducing psychotropics, but actually improving access to psychotropics, and how we do this in a way that doesn't become irrational, that we see here. And we do this in a way that doesn't bankrupt health systems by promoting branded drugs. This is my most important agenda. So we promote generics. We promote a sensible and rational use of medication alongside psychological and social interventions. This is what the global mental health field should be trying to champion.
Let's look at, and then I'm going to go to the NXO, because I want to talk about that in a minute with Angela. Let's go to two countries, nations that have huge populations and huge mental health issues, and that's China and India. And how have those governments dealt with the populations in different ways? And one has progressed, China, and the other not so much.
Well, I think, yeah, you really said that correctly. I think the two countries 40 years ago would have been pretty much at the same level socioeconomically in terms of development. Today, I don't think there's any similarity, actually. India is very much a much poorer and a socially much more backward country than China is. And I think the big difference really is the emphasis that China's made on a public, high-quality education healthcare system that India never did. And that has meant an enormous improvement in literacy, women's agency, a variety of different social determinants that actually ultimately determine the health of a population. India is still mired in its past in many ways. It's seeking to make the transition, but it's still got a huge road, a long road ahead. So this also translates to mental health care. China has invested greatly in a universal healthcare system, and part of that, they put a lot of emphasis on mental health. The 686 program is probably the world's largest publicly financed mental health care system.
What is 686 program?
It's very interesting. It was launched around the year 2001 or 2, when China decided to abandon its previous private focused healthcare system, which was really out-of-pocket payment-based system like India has dominantly. It adopted NCDs, non-communicable diseases, as a major priority area. And quite curiously, and I don't know the exact story behind this, mental illness was identified as a priority within the non-communicable diseases. And 6.86 million renminbi were allocated to the mental health program. And so that's why it's called the 686 program. Nothing extremely dramatic except the amount of money that was put in. But today, it is the largest program publicly financed. At last count, more than 4 million individuals with a serious mental illness, mostly people with psychosis, including bipolar disorder, are now registered electronically within a mental health information system. So it's a mammoth program. There's nothing even remotely to compare with that in India.
And India has a high rate of suicide, whereas China has curtailed that in many respects. Is that right?
Well, that's another interesting, and it's a different kind of question, and links to social change in my mind. China had the highest rural female suicide rate on the planet in 1990. Today, it has one of the lowest. Mm-hmm. India had one of the lowest suicide rates in 1990. Today, it has the highest. And I think it's quite interesting. I mean, I can't say that this is an academic answer, but it's an answer that's based on my examination of these two countries in terms of social change. Where young women's lives, for example, are today in India is where they were in China 25 years ago. They were trapped in rural worlds in a highly patriarchal system with very few opportunities to escape. Today, I think the situation for women in China, certainly in my discussion with my colleagues in China, would suggest it has transformed. Urbanization has been a huge part of that. In India, the truth is, I think the majority of women still find themselves unable to exercise their autonomy, and I think there is an aspiration to do so thanks to education and globalization. So my sense is what we're seeing now is the sort of peak in suicide in young women that we saw in China during their stage of rapid social change and transformation 25 years ago. We're seeing it now in India. The good news is it will improve as women's agency improves.
Angela, I want to, you look at Mexico very closely, and there's been a huge increase in drugs, illegal drugs in Mexico. Mexico used to export their drugs. Now, many of those drugs stay, and they have huge addiction issues throughout the country. What impact has that had upon the nation, the drug war, and also the increasing addiction, and how that is the comorbidity of mental health issues?
Well, the drug war has wrecked lives, both in Mexico and also in the United States. I see it very much as a shared struggle. In Mexico, rates of addiction have gone up considerably, especially to narcotic drugs in the border region with the United States and also in Mexico City. And one of the problems, I think, is that Mexico still presents itself as not really having a drug problem. Certainly alcoholism has been a longstanding problem that Mexico has been grappling with, and there are many, many studies of alcoholism in Mexico. But there's a reluctance, I think, to address the problem with narcotics addiction, in part because it doesn't fit the political narrative that Mexico still kind of maintains, which is that the drugs come to the US, you're buying them, we're getting the guns from you. And so there's a complex, political history that leads, I think, to a reluctance to address addiction with the kind of essential force that is needed right now, because what I see in communities that are not necessarily taken into account in studies is tremendous problems with crack addiction, cocaine addiction, addiction to methamphetamines, to drugs that I didn't even know existed, that are being concocted in labs, particularly along the US-Mexico border. What has happened, in addition to that, of course, there's escalating criminal violence, which has created an environment where people are terribly insecure and are seeking some kind of relief, which too, the people that I was working with in rural New Mexico were also seeking relief. And that relief happened to be in the form of what they called in New Mexico medicina, heroin, and in Mexico City, various kinds of drugs, including alcohol. And so problems with addiction have increased dramatically. People are using at younger ages, and there are epidemiological studies that are just demonstrating this. There are also increasing studies that have shown the damage that the drug war is causing on the psyches of Mexicans more broadly, including children. And what is disturbing to me is the way in which there are many, many studies of the effects of war and trauma in various countries, and only now, I think, is there a growing conversation within Mexico and also in the United States of the trauma of the drug war and the damage that it's causing to the mental health of people in Mexico, particularly in areas that are being hardest hit by the violence in the provinces, but also in low-income neighborhoods and cities and along the border.
If you stretch that out to the conflict issues around the globe and the refugee camps, which have significant gender violence, significant mental health related issues, are there any sort of models that are working inside to trying to address the populations that are currently residing in these war-torn refugee camps around the world, especially in the Middle East?
Yeah, well, first of all, I just want to say something about what Angela said there. Mm-hmm. One of the biggest problems we face in global health, and I think global mental health in particular is no different, is how little evidence-based policymaking is taking place in the world. And I think the fact that, as you mentioned, the war on drugs is perhaps the most failed policy of all times in this field, and that actually the latest opportunity there was for the nations of the world when there was the UN summit to actually take a really cold, hard look at how failed this policy was, completely failed, to actually reverse this policy. To me, this is the real struggle. The struggle that governments around the world adopt attitudes that on the one hand supposedly are to back science, but in fact what they in fact do oftentimes are based on ideology that is independent of science. And I think, anyway, just to flag this up, to me, I often feel we're swimming against the tide, people who work in global health, because our policymakers actually make very damaging decisions.
Let me ask you about that. Let me forget. What are some of the dumbest things you see that are taking place?
Well, I think the war on drugs has to be the dumbest policy in the addiction field. It has to be, by far and away, the dumbest policy. It is destroying not just livelihoods and lives in Mexico, in my own country, in India. I see the same thing in the state of Punjab, where there is an absolute epidemic of opiate abuse, which, according to the estimates, affect 1 in 3 families. That is to say, every third family in the state of Punjab has an opiate user. This is a staggering toll. And the government's response to this is continuing to criminalize both the user and the supply chain. The whole thing is absurd. It's completely absurd. Nevertheless, there are other examples as well. So, for example, in many parts of the world, the lack of access to medicines, because psychotropic medicines that we talked about earlier, because they're believed to be either too expensive or not that effective, is another example of a very poor policy decision. And finally, the complete reliance in global policy on highly expensive human resources to deliver healthcare, even though we have abundant evidence about the role of communities and community-based workers, is one more example. But returning to your question about refugee camps, it's a good way to segue to that. I think we have to, the most important observation I've made, and I have very limited experience, admittedly, in this particular sector, is that everyone who has been displaced by war and conflict, another good example of a very bad global policy to have war and conflict in the first place. Having said that, sorry?
Let's applaud that.
Yeah, there's a wonderful piece by Jeff Sachs last week in which he describes America's obsession, along with many other big countries, with the defense industry as a great example of how enormous resources, both human and financial, are being squandered in the name of defense. Nevertheless, the fact is, we're not going to change that in this conversation. I think we have to live with the reality of millions of people displaced from their homes. I think the most important model of care that I've seen works is to treat the entire population in a refugee camp as a population that has collectively suffered trauma and loss, and that the most effective intervention is to normalize, depending on your age and so on, your lives in those camps, so that they appear as normal as possible to the lives you might have had in your original town. So in case of children, for example, to have a very strong educational system in place within those refugee camps, to give children access to the same educational opportunities they would have had. But admittedly, we also have to recognize that within this universal whole population approach, there will be individuals with much more specific, much more serious, much more clinical, perhaps, mental health needs. And so we really do need to also integrate mental health problems within the overall healthcare system within these refugee camps.
So follow up on sort of that is that diagnostics basically rule mental health and mental illness in the U.S. and Western nations. The WHO diagnostics and the APA, the American Psychiatric Association diagnostics. Where are they relevant around the globe, and where are they not? And where do you see them not as effective?
Well, I think that's a great question. And it also makes me think about, a term that's been thrown around a bit, evidence. What constitutes evidence, whose evidence, and how one person's evidence and sense is another person's nonsense. And I think that this is another major dilemma that we have in the field of global mental health. In addition to evidence, ethics. One person's ethics is another person's non-ethics or lack of ethics. And so where I work in Mexico City, in places that are deemed widely in the public and by public health professionals, and by the government, they're deemed criminal concentration camps. They've been called labor camps. They are essentially
the Annexo.
The Annexo. They're informal, unregulated residential treatment clinics that are run by and for the very poor. Many of whom were in drug dealers and the drug, had previously worked for the drug trade. and or just in the informal economy in general. And they consider themselves a form of mutual aid, a form with a long tradition in Mexico of mutual aid groups coming from a culturally adapted form of AA. But the methods that they use certainly do not follow guidelines by the WHO or the APA. They are methods that make sense to the people that engage them. It's taken me a long time to understand the logic of sense that operates within an exo, because my initial response was a sense of real dismay when I began spending time in them. And in acknowledging the logic of sense that operates there, it's very easy to sort of critique one as being just an extreme cultural relativist or an apologist for a form of, care that is not, in fact, care that is not evidence-based, that is not ethical. But what I aim to do in sort of my own work is to pose the question of how, of trying to locate and understand the ethics and the evidence that are at work in places that look completely nonsensical and unethical. And to pose it as a kind of an opportunity for us to maybe reevaluate what we think, constitutes evidence and whether or not it's something that can be easily transportable from one context to another. Just as what health might mean may not be easily transportable from one context to another too. What works about an exos, places that people are described as being deprived of their liberty and their autonomy because they're taken there against their will, what works for them is that they're not on the streets. They're not, their drugs are not available to them. They have food. They're sleeping in rooms where the floors are not made of, they're not earthen. They're cement. There are blankets. There's community. There are people who share their histories of trauma and violence that they can talk to. So some things do work. But in the goal of upscaling them or criminalizing them, based on their appearance, based on certain modalities of intervention that are utilized in exos that do not appear, that don't align with our kind of conventional programs that we might have in the US that are being exported to Mexico. I think I've witnessed real harm in what can happen. People, an exos being closed, people going back, people being then killed. Families saying, I can't handle this person, the child then being locked up at home rather than in an environment where there is something. So in the absence of anything else, what I kind of aim to sort of think about is to try to understand, well, what is here? And what kind of evidence is this space offering us? And yes, and how can we perhaps improve the conditions, but improving the conditions may not be simply applying certain normative standards. It might look quite different. It might be related to drug policy reform, for example. It might include sort of broader conversations about the drug war that must change.
Do you see a bridge there? Do you see something? I know you spend a lot of time thinking about access to care and how we expand access and how the layperson becomes a healthcare provider, a mental health care provider. What's the bridge you see in what Angela was just talking about? What are the ways in which you can bridge those things that may not look like they are pure helpful resource centers?
Mm-hmm. Yeah, well, I do think that that's a challenge, but it is potentially bridgeable if you acknowledge that there are different traditions of care in every community. I often, tell my students that people have been dealing with mental health problems from times immemorial. It's a human condition that's been around ever since we've been around, and psychiatry has been around only 100 years. And so clearly people weren't waiting for us to come around with solutions. They were doing things, and those things, some of them, were actually potentially very helpful. And I think to rush into a new community and assume that that community had no healing traditions of its own is very naive, to say the best. I think what we have to do is to be humble and recognize that there might be actually some pretty terrific stuff going on there. We need to listen, learn, observe, And then I do think we have to find ways of incorporating that in the biomedical tradition, because the biomedical tradition is just another tradition. But I agree, it has a different way of examining what works and doesn't work, and certainly there is a dominance of that particular paradigm of evidence today. I want to return to my earlier point. Governments are my primary audience. That's who I really work for. And what governments need to know is, what should they purchase? What should they train their health workers to do? And it's a constant tension. To what extent can we incorporate these highly contextually sensitive practices within something that can be scaled up for 1.2 billion people in India or 1.5 billion people in China? And that's a continuing tension that I think we have to accept is real, while at the same time we shouldn't throw the baby out with the bathwater and reject local practices. I want to finish with one example, a very concrete example in my own work, in which we've tried to do that. And that example is the incorporation of yoga within mainstream mental health practice. Now, of course, this probably happens in Menlo Park as well, but I was talking more about
I think so.
I was thinking more about India from where it actually originates. I think the fact that the government has adopted the inclusion of yoga and Ayurveda, which is the Indian herbal medical system, as a mainstream medical practice has made it much easier for us, because there's a policy mandate here for us to explore how these different practitioners could actually work collaboratively together at the level of the population to ensure that people have choice, and that often these are not competitive practices, but in fact they're truly complementary.
How do you both of you still see the stigmatization of mental illness playing out in Mexico and around the globe? And here in the populations that you work with, undocumented immigrants who come to the US from Mexico to work. Stigma, how significant of a global problem is it?
Well, in the communities where I'm working, really, they're therapeutic communities. What works, in a sense, is having a witness to pain. And so the environments where I work, both in Mexico City, but also in Redwood City, where there are annexos here too, that serve primarily undocumented Mexican immigrants who have a tremendous amount of anxiety and stress from everything from being undocumented to the cost of housing and phone calls late at night from family members back home who are being extorted. There's a tremendous amount of anxiety among the undocumented community in the Bay Area right now. And one of the things that they receive when they go to these therapeutic communities that I work in, that are informal, is a sense of being heard, a place where the stigma that they may feel can be assuaged somewhat, because you're in a community of others who are like you, who are otherwise outside of that world, perhaps stigmatized or afraid. And so I think stigma remains a challenge. And I also think that it's easy to focus on the stigma of mental health problems without maybe thinking about the way in which perhaps it's truly the stigma of being an undocumented laborer that is perhaps most distressing for someone, and how that feeds into one's psychic life, the pressures and struggles that they feel, feeds into their depression, their anxiety, their panic attacks that they have. So it's one thing to focus on just the mental illness part, and another to sort of begin to really think about how that is shaped by the broader sort of social, cultural factors that play into it. And I think in the communities that I work in, the question of stigma is much more local. The focal point of it has to do with labor practices, not being considered a full citizen, feeling very much excluded, feeling marginalized in the communities in which they live, feeling afraid. Those are the sources of anxiety that I think ultimately feed into mental illness. And I'm particularly concerned with kind of addressing those sources of stigma.
I would like to talk about a different kind of stigma. I think this is to complement what Angela just said, and that is about the stigma about mental health problems that pervades every level of decision-making in society. For example, the amount of money we invest in mental health issues or care, to the amount of human rights attention we give to mental health care. And I often point out that in most parts of the world, people with mental health problems are either incarcerated in prisons, such as here, or they live on the streets, or they're denied education when they're children because schools will not be prepared to keep children with intellectual disabilities or mental health problems, etc. And I often say, imagine if all these people had HIV. Imagine for a moment that we did this to people with HIV, which we did do in the 90s. How outraged everyone would be, from the president downwards. But that this continues in this fashion, and most people couldn't care that this is actually happening, is a real deeply troubling thing for me. It should be deeply troubling for everyone, really, that we allow people with these conditions to be disadvantaged in such an unjust and unfair way. We don't tolerate this for any other health condition. Why do we tolerate it for mental illness? And I think it has to be somewhere deep down. There must be some sense that these human beings don't deserve our compassion.
Where do you think that comes from? Where do you think you're talking about stigma, you're talking about, where do you think this emanates from? Every sheriff in America knows that they are the most significant warehouser of mentally ill in the nation. You talk to the sheriff in Cook County, Illinois, you talk to the sheriff in Los Angeles County, they will tell you they're warehouses for mentally ill. Where does this come from?
Well, I'll give you, I don't have a straight answer to this, but I have a few theories. The first is the notion of individual responsibility. That is to say, if you use drugs or you become depressed, that somehow something in your personal choices was responsible for this. So, really, this is your hell because you brought it on yourself. There's a part of that. It's not entirely, stigma is a very complex issue. In my own understanding, that is one part of that. The second is, to be quite honest, psychiatry has played a huge role with stigma too, because the kind of treatments that we continue to deliver in most parts of the world are nothing short of terrifying. They are essentially delivered in appalling institutions that you may not see in this country anymore, but which continue to be the mainstay of care in most parts of the world. Essentially old colonial asylums in which you'll be packed together like sardines, often in the most inhumane circumstances. So we perpetuate fear and stigma through our very institutions. And the lack of real engagement of the profession with reform is another part of that continuing stigma. The third is, I think, the idea that mental illness somehow is untreatable, or that it's something that's less important than, because it doesn't kill as often as physical health problems, is another source of stigma. And finally, there is this kind of question mark, is mental illness real at all? We don't really have a blood test or an X-ray or something can show that such and such person has an illness and such person does not, in the same way that we can do with TB, HIV, and a host of other conditions. So I think there's also that question mark that many people have. Is this just a medicalization of social suffering? And sometimes it is. But sadly, I think that idea has extended sometimes to actually denying that mental illness exists at all.
Where is the hope? Where is the bright side? Where is the... Let's close with that from this section. Where is, what do you look at when you go around the globe and when you see in Mexico and other places, what is the bright side of how this is going to alter, be changed? Where's the progress?
Well, I can give an example. In a lecture in my medical anthropology class on Monday, we were reading some of Joan Didion's work and talking about illness narratives, and we're engaging her book Blue Nights. And I talked to my students about how difficult sometimes it is when we're busy, we're working, that there's a certain corner in Oakland, I live in Oakland, California, that I avoid because I know there is a homeless person there, and that if I pull up to him, I can't look away because I know that's wrong. But sometimes I also just can't engage him because it's too much, it's too taxing. And I think this has something also to do with why it's so hard to deal with mental illness, or why people are even question it, because it requires a level of human engagement, ethical engagement, being exposed to the pain of another, often for very long periods of time. That, you know, and I told my students that after engaging with Didion's work, I knew that when I drove home, I was not going to avoid that corner where I knew this particular individual would be waiting, and he would see me and he would ask me for money, and that I would go and I would have a face-to-face moment with him. And although I was in my Prius, you know, getting ready to speed by, but nevertheless I would have my moment with him. And I did. And I think a moment of hope for me is when I'm engaging with people, when engaging with another who kind of makes a claim on me, says, look at me, look at the way that I'm suffering, and the willingness to do that, and to see them, and ultimately to not turn away. And one of the things I think that's exciting about this thing that we're calling the global mental health movement is the desire of young people, my students, to become engaged, to not look away, to be open, to want to make a difference. I see that, you know, on the campus every day, and in my life, and among my friends, a desire to engage with the world, and that means to engage with the suffering of the world, which often includes mental illness. And so, my hope is that people will remain open and not, you know, and if one day they can't deal with it, they make sure that the next day they do, and that they allow themselves to be exposed to the challenges that exist and to try to find a solution.
I agree. You know, I think the growing interest of many different sectors of society with this cause, the growing identification, is certainly something that we should be very hopeful about. One particular sector, which I'd like to end with, is really about the sector of people with mental health problems. In my sense, the growing agency of people with mental health problems, and that is something that we as professionals, academics, and others with a lot more power must do everything to support, but be really hidden behind in the wings, as it were, is something fundamental to my own work, to enable agency and platforms for people with mental health problems to speak out about their own illness. You know, I lived in Zimbabwe for several years during the mid-90s. So I saw the horror of the HIV epidemic unfold. And at that time, I kind of remember feeling utterly hopeless as well about HIV. You know, it seems such an unjust situation that people in San Francisco could live with this disease with medicines, and that people in Harare died like flies because of a variety of stigma-related issues attached to HIV in those days. Consider where we are today. I mean, surely this has to be the global health success story of our times. And if I look back historically and think, you know, what was the single most important factor that triggered the transformation of evidence into practice in terms of the right to care, was the user-led movement, in my mind. It was a treatment action campaign of South Africa. It was people with HIV going out on the streets and shaming countries, shaming governments, shaming pharmaceutical companies, etc. And I think we're beginning to see that in the mental health field. People standing up on stage and saying, I live with schizophrenia, and I have the right to a life with dignity. And you have the responsibility to make sure that I have that right fulfilled. I think that has to be the most hopeful statement of all.
Thank you. I just want to say one closing comment before we take questions from you, that last year Vikram Patel was given the enormous honor of being one of the 100 most influential people in the world. And in the tribute to him that was written in Time magazine, the person who wrote it talked specifically about the passion, the humility, and the sense of justice and human rights he brings to the issue. And I think you've seen that here today. So thank you both for joining me.
Thank you.
So after that terrific panel, I'm sure there's going to be questions. We have microphones here and here. You can just line up and ask them. Please keep them short, no speeches. And just as a reminder, this is filmed and goes on the internet, so it may feel confidential, but it's not. So don't disclose anything you don't want the webs to know. David?
Thank you. Hi.
Distinguished member of our faculty, David Spiegel.
Thank you. And I also run the Stanford Center for Integrative Medicine, so I'm very open to combining traditions and treatment. Thank you both for the work you do and for a fascinating discussion. It strikes me, though, and you were getting at this, Dr. Patel, at the very end, both of you were, that there's a kind of contrast between the global view that people suffer because of economic injustice, because governments misspend money, because of violence and poverty. So let's not let them blame themselves for their mental illness. And on the other hand, one of the premises, both of biomedicine, which is I have to admit I have bipolar disorder, or of AA, which is the most successful social program for treating alcoholism, you have to start out saying, I'm David, I'm an alcoholic. So how do we deal with that conflict of the fact that much of what people suffer with is a result of things that are far beyond them, and we're only too happy to blame them for something they don't control, and the fact that to get better often, it is necessary to own what you are and demand resources for help. I wonder if you could comment on that.
So, so first of all, I would not be an apologist for the biomedical model. I mean, I think the biomedical model has and can bring transformative changes to the lives of people. I think we have to move beyond this dichotomy. This dichotomy is unhelpful. HIV is also a social disease, you know, but you don't hear people arguing whether or not the rights of men who have sex with men should be the primary thing that we should focus on, as opposed to the right to access to antiretrovirals. We can comfortably talk about the rights of sexual minorities and the rights of people with HIV without any sense of conflict between these two. And I think we really need in the mental health debate to be able to mature to that stage, where we can talk about the right to a fair world as a way to prevent mental health problems and address their mental health needs, alongside the right to access psychological treatments and drugs as needed for their condition.
Thank you.
Over here. We'll go to
She's
stage
here
left.
first if she wants to go. Oh, that's fine. Okay. So I'm a postdoc at Stanford, and I wonder how is the precision medicine movement, as well as like all those cutting-edge technologies, such as genomics, changing the way of prediction and prevention of mental illness. And then you compared many times of HIV with mental illness. So I'm also wondering, like, when should we imagine a time that we can screen for the high-risk population, like beforehand, before the people really get sick? So, and then really do the preventions for those, such as we do with diabetes or other high blood pressures.
So I guess my view on this, and maybe Angela will have a view, is that personalized medicine is really very much in its infancy in the mental health field. I don't think we can really compare this with, say, cancer, where I think there's been a much more significant developments in that area, in part because we still have very weak, plausible mechanisms for many of the conditions we deal with. Having said this, that doesn't mean we can't do prevention. Prevention in our field must lie in the social environments that people find themselves in, particularly in the early stages of their life. I think we have very, very good epidemiological observational evidence to show that, for example, deprivations in childhood of all kinds are profoundly related to mental illness in later life. I don't think we need to have a biological mechanism to demonstrate. We will find one. There are plausible theories on plasticity of the brain, etc., that perhaps give us some plausible pathways. But I don't believe we should wait for action to actually prevent mental disorders until we demonstrate a genomic or a biological pathway.
I would just agree with that. I agree very strongly with that assessment. Yeah.
Hi. I have a question for each of you, if that's okay. Professor Garcia, on that last point that you made, I think your point being that the crux of the issue a lot of times is getting to the human connection and really being with a person, and that's the moment where healing can happen, and that's really hard for people to do. And even you talk about it as being taxing, right? So I'm wondering if there's like a space that we can get at that fear of human connection and where it's not taxing anymore, where we find something really beautiful in like being with a person and like helping them through struggle.
Or just live with the taxing nature of it and talk about it and not feel like it has to be disavowed or ignored or denied. And I think examples of this for me come through literature, film, which is why I so often incorporate them into my teaching. Didion's work, for example, and just the work of anthropologists that spend a lot of time hanging out with, like a lot of physicians do, hanging out with with people struggling and suffering, and being willing to remain in that struggle, which can be so difficult, and but is, I think, and ultimately it's a mode of human engagement that I wouldn't want to see disappear with advances in personalized medicine and high-tech medicine. I do worry a little bit about that element of care being lost with the growing, the emphasis on technology and high-tech medicine.
Yeah, that's actually exactly related to my next question to Dr. Patel. Are you doctor? Are you a doctor? Yes? Okay. I wasn't sure. I don't know
I'm
what
Vikram.
your title is. Vikram. Okay. Vikram. You were talking about like Silicon Valley IT tech going to other parts of the world and helping people get access to medical knowledge and healing practices, hopefully. But what about the issue of like that format being in a particular language and in a particular mode of being that is bred out of minds that live in this space, and that being exported to other, like how do you deal with that?
Do you mean language as in the spoken language?
Literally, yeah, English being pressed, even if it's translated, like.
No, well, I mean, yeah, clearly this would apply in the same way as we would with any other face-to-face engagement. I think the digital world simply is another platform, but the way you communicate and engage people remains exactly the same. Whether you're doing a face-to-face engagement or a digital engagement, you have to do it in a way that is going to attract and engage people within that whole program. That requires profound attention to language, to attitudes, metaphors, idioms, etc. The digital space is not free from that.
Right.
So certainly, for example, apps that might be developed with a particular sensibility in mind, say, for example, people in a more English language speaking industrialized setting, I doubt will just easily translate. The theory behind the app may be universal, but the presentation of the app, even that is questionable, but at least there's some reason to believe the theories of mental health experiences are actually cross-culturally applicable. But actually the way they are explained and how they are translated in different parts of the world require profound adaptations.
Okay. Thank you.
Dr. Patel, you talked about, you made the point about HIV, that we wouldn't tolerate, as a society, not helping people or giving people access to care who have HIV. But people with mental illness often don't want care. And that, I think, is one of the things that doesn't get talked about. And I, have personal experience, a family member who, goes off medication and doesn't think he needs it, and there's a denial. So there's a number of factors that are different from other, physical diseases.
So you're quite right, and thank you for pointing that out. Actually, I do think the comparison falls down on that very fundamental issue. It falls down actually in two ways. First of all, HIV is one disease. Mental illness is not one health problem. It's a very complex array of conditions. It's interesting, I work a lot in the autism sector, and most people now in the autism sector don't see themselves as having a mental illness. In the autism sector. I work a lot with people with autism, and most people with autism would not wish to be clubbed together with people with mental illness. So, within the mental illness group, there are many subgroups, and there's stigma between these subgroups too. Ultimately, I think people with schizophrenia will be the basket case of mental illness. They will be people who no one will really stand up for because it's the least attractive human condition of all. Depression, for example, is making its transition out into the open. I read recently that America's most famous musician, Bruce Springsteen, has written a memoir about depression, but interestingly in India, the most famous actress that India currently has, Deepika Padukone, has publicly come out with her depression and started a foundation for depression. So I do think that comparisons fall down, and I do think you're right that there is a fundamental issue for people with serious mental illness on whether they want care or not, and I think we have to engage with that. We have to engage in a caring context how we can support decision-making as opposed to force interventions on people with serious mental illness. Supported decision-making is not easy. It requires a lot of skill. It requires a lot of human resource investment. But I do believe people have the right to supported decision-making.
Thank you.
My question is related to the question from the previous student, but as we seek to perhaps find solutions through tech and the marriage of tech with mental health care, how do you think that people in the tech field should work toward that sociocultural competency and building that into the theory that's applied through these mental health care apps? For example, while the theory, as you said, might be sound and might be widely applied, how do you build that competency into those different ways of communicating with different groups of people?
Well, I think that's going to be a huge challenge. I mean, it's still challenging to talk about cultural competency with physicians who may have taken a lot of coursework in anthropology and, you know, their college years, and so then working with the tech sector who perhaps has no training in this realm, it's even more challenging. So I'm probably not the best person to answer this, and I must admit I'm deeply ambivalent about these, you know, the technologization of health, and both as it's practiced globally, but also just within, you know, the U.S. and because of what is this picture of health that we're creating, and it makes me reflect a little bit on the last question about people who don't necessarily want care, or the complexity of that, and a lot of people with mental illness not wanting to seek care, or not wanting care, or refusing care. I think that that is a legitimate choice too. It makes me think of Ivan Illich's essay, "To Hell with Health," and the decision among people, some, not because we shouldn't, you know, get health or care when we need it, but what is the picture of care that's being provided to us? And I think that refusal for a particular picture of care that is being provided is a right. And so, and I'm a little bit concerned about the picture of healthcare that might be, you know, developed by young entrepreneurs who perhaps haven't necessarily had any kind of cross-cultural training or really engagement with any community outside of Palo Alto, to be blunt. And maybe I shouldn't have said that now that I've just remembered that this is going to be on the internet. Suddenly a little anxious.
A side comment about Bruce Springsteen, and I heard when he was on his book tour, someone asked him, well, you look so happy on stage, that you can not be happy on stage and still have depression. It's the conundrum.
Or the other thing is you have everything.
Yeah,
Yes.
right.
Why are you depressed?
Yeah, the great thing that Springsteen's response to that was, you know, oftentimes I look at that guy on stage and I say to myself, I wish I were he.
One of the things that really is interesting, that's got a little touched on, but doesn't get part of the dialogue, is the role of families, both in the interprevention, which you touched on a little bit, but also to leverage the social resources and the social network and fiber to really be the scaffolding that we need to help any health condition, especially mental health. Could both of you speak to how you've seen this play out in your particular communities and work, as well as the policies that need to be put in place or are in place that could help leverage that role more in helping mental illness?
So I think, you know, I can give you a very concrete example. I work very much in the area of psychotherapy, brief psychotherapies for mental health problems in different cultural contexts. And one fundamental area where these don't translate very well from the West to where I work in India is exactly the role of the family. It's impossible to imagine giving psychotherapy in India without engaging the family, not just as a potential secondary you know, addition to your therapy, but actually as a primary engagement. So that's one example, and more broadly, in rural India, it would be impossible to work around issues of stigma and inclusion without involving the community. You can't even do it. It has to be bottom up, because otherwise it will simply miss the mark.
Yeah, likewise, in Mexico and among Latino communities, there's an idea, particularly within addiction, that if the family is too close, they're being codependent, and the family should, there should be tough love, and you should separate, and you should, put your foot down and stay away from your addicted child. That narrative doesn't really work very well, particularly in communities where the family really is the primary resource for care and for social support. And too often in the clinics that I've worked in the United States, particularly in a detox clinic in New Mexico, when there would be, for instance, a mother and a child both addicted to heroin, they could not seek treatment together, even though they lived together outside, of the therapeutic environment, and so just the model just did not align with the cultural practices and values of the communities in which the interventions were being directed. So I think, a real attentiveness to kinship, to the complexity of kin relations, and to really seeking to understand them, in a very detailed, culturally located fashion is absolutely essential.
Yeah, my question is related to the issue of stigma, and I think Dr. Patel said that one of the issues around that is that mental diseases are not seen as fatal, where in fact the latest CDC data shows that for the ages 10 to, I think it was 45, suicide is the second leading cause of death. It's just behind basically auto accidents. My question is, how do you suggest addressing that with the general population? And actually, that is sort of an enculturated thing in all cultures, in my understanding, though I don't have world data. And even in professionals, clinicians, they don't receive adequate training in suicide itself. That would come out of an association of suicidology, great national study. At least in America, they don't receive that training. And how do you suggest addressing that issue if we're going to make any headway at all in brain diseases?
So I think changing hearts and minds must involve packaging this kind of knowledge in a way that is meaningful and engaging for these audiences. So the thing about suicide is very interesting. The majority of people in global health and development will think that suicide is completely your personal choice. I very frequently meet people who say, well, he had a hard life. He decided to end his life because it was a tough life. She had a hard life. She ended her life. What is the business of the health sector in this particular area? You might find that horrifying to hear, but actually this is a very common, sort of discourse. He chose to end his life. That's not our business. As opposed to dying because you have HIV. You really didn't choose to end your life. You were infected, etc. Although even there is a personal agency there if you go all the way to the origins of the disease. But this is a challenge. How you package is very important. Do you know suicide in the global burden of disease, which is a very important indicator, it's a very important text in global health. Suicide is a separate cause of death. So no one who is allocated to the cause of death of suicide is because they have a mental illness. They basically had an injury-related death, like you got hit by a car. Mm-hmm. So as a result, according to the global burden of disease, nobody on this planet dies because of depression. Because depression doesn't kill you. So this is the way we classify causes of death. There is a real problem in how you ascertain and attribute death to different, perhaps more distal health events. And I don't think we have an easy answer to that. Correctly estimating the number is extremely important, but also correctly communicating that knowledge to audiences is still a challenge that we have to actually address. I'll say one more thing about mortality, which I think, again, we don't talk about enough, is that people with schizophrenia die 20 years earlier than people without. That's another scandal. Schizophrenia is not a fatal disease. It doesn't, in and of itself, kill you. You die because you have unfair access to physical and psychiatric care and social services. It's a huge scandal. Think about it. If a non-fatal condition killed you 20 years before you should have, you'd be outraged. Somehow, no one is.
We'll take two more questions here and there.
So my question concerns a really fraught ethical issue, and I don't think it has a clear answer, but you might want to engage with it personally, both of you. So you mentioned, Dr. Patel, how psychiatry is complicit to a certain extent in the colonial asylums or globally in kind of very coercive forms of treatment. We know, though, that a lot of these coercive, often violent forms of treatment for mental illness are run by communities and built on local communal values. So my question concerns, what should our position be? Should it be an unequivocal kind of human rights position that condemns these places? And if so, how do we recognize the fact that in many cases local cultural values in a way support, for example, the use of violence for mental illness treatment, or just considering that as a hypothetical possibility, and how the human rights critique is based on liberalized sensibilities that deny the value of engaging with pain and suffering as the mode of recovery. I'm not sure if I'm making myself clear, but it's...
Well, there's one question, there's multiple levels to your question. My own view is one can never allow popular ideas to determine how you treat people. If we did that, we would, goodness me, we'd have capital punishment everywhere. Well, actually, there is capital punishment. Sorry, yes, maybe wrong country to say this, but you know,
there may not be in 2 weeks here in California.
Oh, good, all right. Well, good on you. I hope you don't have it. But you know, seriously, populist instinct is hardly the driver of how we create a better society. It can never be. It must be taken into account, but we can't be primarily driven by what people would like to do as a populist instinct. As far as mental hospital goes, I used to be a votary for shut them down. I'm no longer. I'm not, because what will we do with the hundreds of thousands of people for whom this is their only home? As awful a home it may be, the alternative is the street. And I know what it's like to look at people living on the streets of Delhi or Nairobi. It's actually worse than a mental hospital. So I think my current position is reform, making these open institutions, removing the locks, removing the doors that are locked, and creating a modern mental hospital in which the community and the hospital are completely integrated. And actually this is happening. It may sound like pie in the sky, but actually there's a program called Thrive, which is going on in India, which is working with mental hospitals to make them open institutions in which people actually can move in and out as if it was just any other district, or any other healthcare institution.
Yeah, maybe we should go to the last question, but just to say that, you know, in the context in which I'm working, I completely agree. You know, initially my impulse was, when looking at a nexus in Mexico City, that, you know, where were the, you know, civil society organizations, where the human rights organizations, why weren't they addressing these you know, terrible conditions and shutting them down? Now that is exactly what they're trying to do. And I've sort of become to take the opposite position, in that the world outside, the world that exists without these places, is even worse. And so maybe taking more of a harm reduction approach and thinking of, you know, small, sensible ways of improving the daily life, the conditions within these sites. And in order to do so, actually really understanding what the conditions are and what is behind them. Is being, you know, really fundamental to that project.
I have a question associated with the topic of stigma. Do you feel like Hollywood films and television could help in any way in kind of eliminating or reducing the stigma, or do you think that there's kind of enough of that and it has been ineffective right now, or do you think it's actually made it worse because they portray mental health in a sort of a negative manner? Like, do you think seeing people, you know, with mental illnesses that they can live a normal life, do you think that could help with the stigma? Or do you think that we already see that enough in films that it just hasn't been effective with helping people kind of get rid of these stigmas?
Let me make one comment about that. I interviewed Glenn Close, the actress, earlier this year, and she has a mental health foundation. Her sister's bipolar. And she said she will never, ever do a motion picture again, which depicts someone like in Fatal Attraction. And she said the stereotypes that she did in some of her films were destructive and continue to stigmatize the mentally ill. And so I took from her a real understanding, and she said, I'd like to see Hollywood really change the way in which to go from One Flew Over the Cuckoo's Nest to As a Mind as a, I forget the great film about the schizophrenic, but to, pardon? A Beautiful Mind. And there's someone in the film industry who knows the crisis of mental illness because of her sister and the sister's pain, talking about how films do have meaning, how they do have larger context.
I think that's a great answer.
Thank you for joining us.